Welcome back to the Rush Lupus Clinic and LSI educational event. We're about to get started with our second presentation. I did want to review that today's event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendation. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois website.
So that was a wonderful presentation with Dr. Cherney, and he's new to the Rush team, right, Dr. Jolly?
Yes, he finished his fellowship, and we are very excited to have him in the clinic. And he spent training with me also in the Rush Lupus Clinic itself. He's a bundle of energy. He's a researcher, educator, everything. And I have to tell you, he has a green thumb in our office. He's known for his green thumb. His graduating gifts to everyone were plants, which I have in the background.
That's the green that's behind there. Nice.
Yeah.
Well, that's nice. That's great. You've turned out some really great fellows. We're still in touch with some of them. So yeah, a lot of people have a lot of stuff to say about the Rush team. Hi, Dr. Nika. You know, so many people have wonderful things to say, but in addition to that, the Rush team really knows how to have a good time. And they send us pictures, so we have proof. So I'm going to pass it over to Dr. Jolly, who's going to introduce Dr. Nika, and I will touch back with everyone. If anyone has any questions, either chat them to everyone. You can chat them to me or to Lisa. All right, with that, I will pass it over to Dr. Jolly.
Wonderful. Yes, our Rush Rheumatology team really does know how to have a good time. We just had our holiday party, and we all work very well together, learn together, do great patient care, as well as hang out together. We're a great team. We're a great team. So it is my pleasure to introduce my friend and my colleague, Dr. Nika. Dr. Nika did her fellowship from University of Illinois at Chicago, and she is an assistant professor. She's been with our Rush Lupus Clinic for some years now, and she provides care at Rush, as well as she provides care to patients at Cook County. She's an educator besides providing patient care. She's also participating in research related to lupus, especially with the clinical trials with Lucent Network and other pharma clinical trials in lupus. So she's very engaged with that. She's also an active volunteer engaged in the community with events such as this, as well as in the community with a Lupus Society of Illinois. She's involved in educating physicians about lupus, other trainees, as well as patients and their loved ones. I have to tell you a fun fact. She is a poet and has a book to her credit. So Dr. Nika, please go ahead with your presentation. I welcome you. Dr. Nika, you're muted. You have to unmute yourself.
Okay, sorry about that. So hi, everybody. Very excited to be here this morning with all of you. Thank you so much, Dr. Jolly, for the introduction. There is no greater mentor I could ask for. I've been at Rush since 2014, and I was fortunate enough to meet Dr. Jolly and be part of the lupus clinic and get affected by her passion for lupus. She's a great educator. She's a great patient advocate, and I'm really excited to be part of our lupus clinic team. So without any further ado, let's start and talk about different types of lupus today. So all of you, I'm sure, know a lot about lupus, but I always hope there is something to learn. We all have something to learn from each other. As doctors, we always learn from patients too. So at the end of the presentation, I'll be happy to take questions and discuss, what your thoughts are. So let's start with What is lupus? So lupus is a very complex autoimmune disorder. And what is immune system? You know, Dr. Cherney explained it very well. I could not do a better job. He explained it in very lay terms. And immune system is a very complex mechanism through which our body recognizes the, you know, the body invaders, the germs, and fights them and so clears them. But in lupus, accidentally, the immune system is attacking our own body cells and tissue, resulting in inflammation and damage. Lupus can affect many parts of the body, actually virtually can affect any part of the body, but most often can affect the heart, the joints, the skin, the lungs, the blood vessels, liver, kidney, nervous system, everything, visible and invisible. So what's unique about lupus is a waxing and waning kind of disease with long periods of quiescence, and then all of a sudden goes into a flare, and that's very, you know, it could be very unpredicted. It can happen over a course of several months to years. Some facts about lupus: it's more predominant in females with a ratio of 9:1, especially during the childbearing years. 70% of lupus patients are females between ages 15 to 45, and that drops, you know, later in age. Lupus happens more commonly during early years of life, but it can present at any age. Disease is rare in males, and I don't know how many males we have in the audience today, but you know, it's not as common. And you know, when it happens in male, though, it can be more severe. So it doesn't have like the specific pattern we see in females. There is about like 1.5 million cases of lupus in the United States, and the incidence is about 2 cases per 100,000 a year, with a prevalence of 17 to 48 per 100,000 of population. So it's not very common, although, you know, we're all here talking about lupus, so we're all very familiar with it. It's more common in people of color, especially in Afro-Caribbean females, where the ratio is as high as 1 in 250. African American to Caucasian ratio is 3:1, so 3 times is more common as in Caucasians. Child of a mother with lupus has a much higher risk of developing lupus, and people with a first-degree relative with lupus have a much higher chance of developing lupus as others without. But what really causes lupus? That is a, you know, not entirely understood phenomenon, and there is different mechanisms which have been entertained and interact with each other, including genetic, hormones, and environmental causes. As far as genetics, there is over 40 different genes that predispose people to developing lupus, and many of these genes encode components of the immune system. But these genes need to get activated somehow, and in that plays a role the environmental factors, including the light, the chemicals, certain drugs, certain viruses, smoking also, it's very, very important risk factor, and also some hormonal changes, especially estrogen levels. People with high estrogen levels are more prone of developing and having a worse disease. So what is ANA? We all hear about ANA. Maybe the first thing that just kind of raises the awareness about lupus is ANA. It stands for anti-nuclear antibody. It's an important screening tool for people with lupus. But the positive ANA by no means means that the person has lupus. We see positive ANA in up to 30% of general population in low titers, and the low positive ANA of 1 to 160. I'm sure a lot of you have heard about ANA and the titers, but when the titers are low, the likelihood of developing lupus is very, very slim, so less than 2%. It can be positive in healthy individuals, especially in people that might have had a recent infection or other autoimmune diseases, such as autoimmune thyroid disease, for instance. And it can be negative also in certain types of lupus. So this talk is about different types of lupus. And when we talk about cutaneous lupus, we can see that people might have a negative ANA. So that doesn't necessarily correlate with their disease activity. And besides the generic anti-nuclear antibody. There is also specific antibodies such as anti-double-stranded DNA, which is way more specific and which may correlate with the disease activity. And certain antibodies such as double-stranded DNA, we check periodically because it correlates with the disease activity, and especially some maybe silent manifestations of lupus such as kidney disease. Anti-Smith antibodies, also another specific antibody that we see in lupus, and antiphospholipid antibodies, which can stand alone or could be part of the lupus diagnosis and are a higher risk of people developing clots or like a DVT or a P or a fetal loss miscarriage. So we have criteria for diagnosing autoimmune conditions and all the diseases for that matter. And the criteria are not meant to be counted and used for making a specific diagnosis. They're meant to stratify the patients for research purposes. But we go by this criteria as a guidance in our head to make a diagnosis. And part of the criteria for lupus is Malar rash or Discoid rash, different type of rashes that we're going to talk a little more specifically about, sensitivity to sun, ulcers in the mouth and the nose, arthritis, fluid around the heart, the lungs, kidney disorder, neurological disorders, anemia, abnormal blood tests, and as I said, positive ANA antibodies. But how many lupus types are there to discuss about? You need to be kind of like familiar with different terminology, because having systemic lupus is different from having cutaneous lupus. And there is also another entity called drug-induced lupus, which might be something temporary and something not lifelong, like immune lupus, neonatal lupus, lupus that affects the babies of the mother with lupus. And let's talk a little bit about these different types of lupus, including, let's start with drug-induced lupus, because there is many drugs, including antibiotics, blood pressure medications, thyroid medications, etc., that can induce the immune system into like going into hyperreactive state of creating antibodies and attacking our own cells. And drug-induced lupus can be systemic lupus or just skin-related only. When it affects like the whole system, systemic lupus, it can happen, in different time periods of drug exposure, including like from 1 month to several years. And as I said, there is many drugs. I included only a few there, but can you avoid these drugs in order not to develop lupus? I mean, that's something that it's very uncommon, and if it happens to someone, it's unfortunate, but you cannot avoid all these drugs, because a lot of these drugs are very, very commonly used, like for hypertension, for instance, or thyroid disease. So in this case, when this drug somehow it's triggering the immune system, we see that the positive ANA starts surfacing, and some other specific antibody we call antihistone antibody. And the clinical features are pretty similar to the systemic lupus: arthritis, myalgia, rash, fever, serositis, or fluid around the lungs, around the heart. And in some other cases, it can affect just the skin, and it's called drug-induced skin lupus. And a notorious drug for developing that kind of lupus is hydrochlorothiazide, and that, along with some other drugs like other blood pressure medication, can have an incubation period of days to years. So it doesn't necessarily have to happen within the first few days of exposure, and it can trigger some antibody like ANA and some other antibodies and antihistone antibodies that are common. And I mean, once we kind of recognize that this drug might have been the culprit of developing this skin disorder, we stop the drug, and usually that kind of clears in a few weeks to months after stopping the medication. So besides the systemic lupus, there is just the lupus that affects the skin. We call it cutaneous lupus. Lupus-specific lesions can be acute, happening like very, very acutely, and usually they don't last very long. They can happen over a longer period of time, and we call it subacute cutaneous lupus, or it can be chronic. It can last like longer than 6 weeks to like several, months and years. Besides the lupus specific skin lesions, there is also some lupus non-specific lesions. I mean, I'm not going to go over details about that, but there is lesions that can be seen in other autoimmune disorders that we see in people with lupus. And we're going to go over some pictures to, kind of have a better understanding of what we're talking about. So when we say that lupus affects the skin, it can have many different manifestations, including photosensitivity, like when we're very sensitive to the sunlight and we develop a reaction to that, to Malar, which is the most common lupus skin manifestation. But let's talk about photosensitivity. It's a skin rash as a result of an unusual reaction to the sunlight. And, we get that by patient history. The patient tells us that I've been in the sun and then all of a sudden my face started burning. It's in the sun exposed areas. It could be acute or chronic. It can last, a few hours to, several weeks. But usually it resolves very quickly. And the most typical one is the butterfly rash, which sounds kind of cute. It has a pretty name, but it's not cute by any means. The people that have it are warriors. They might be suffering from, from itchy skin to burning, and, people stare at them and they feel very uncomfortable. So there is, this fixed red flat or raised over the bridge of the nose and the cheeks, and it spares the nasolabial folds, but it's very uncomfortable. It's very visible, and there is different complications. But usually we see that when lupus, it's acute, it's acting up, and that's a sign of disease activity. Besides the butterfly rash, there is different types of rashes. Discoid rash is one of them. It's a raised kind of rash with more scaling, can be scarring, can be lasting. And this is one of the most difficult type of rashes that, we deal with, and it's very hard to control. It can affect any part of the body. It can affect from hands to face to all over the body. And another type of rash, it's what we call subacute cutaneous rash. This is also a manifestation of systemic lupus. It can affect upper chest, upper back, the arms. Is difficult to treat as well, and it shows that the lupus is active. There is other types of cutaneous lupus which are more rare, and they're not very, very frequent, but they're very, very difficult to treat. And one of them is called paniculitis. It's when the lupus affects the skin in very deep layers, and it can cause disfiguration, very hard to control. What about the hair? Lupus can cause different types of hair, from hair loss to thinning to patches, which we call alopecia. And it can be chronic or it can be acute. When it's acute, when it's like very active, you see that the patches are red. They're very, very active at that time. But then, when kind of the acute phase resolves, they can leave scarring and, can be very uncomfortable for people that deal with it. Besides the skin, lupus can affect the oral and nasal mucosa. It can cause ulcers. The ulcers can be anywhere in the mouth. Usually they're painless, but they can be sometimes can be very uncomfortable, and they're a sign of active disease as well. There's other types of skin disorders that we see in lupus that they're not very unique for lupus, but very, very common, such as Raynaud's phenomenon, when the fingertips usually change color upon cold exposure. And there is something we call three-phasic color changes. They turn from pale to white to blue, and then they start going back to the normal color again. Skin rashes in lupus have a lot of mimickers. So having lupus and having a skin rash doesn't necessarily mean that the rash is related to lupus. There is other disorders that can be simultaneously seen, such as people with lupus might also have rosacea a different type of skin rash that affects the skin, but as doctors we can recognize some differences, and then we can make that distinction so we can treat differently. There is other types of autoimmune conditions that can cause skin rash that sometimes it's very hard to distinguish. A biopsy might help in that case, and so it's just that we need to be aware that, you know, skin rash and lupus doesn't necessarily correlate. It can affect all kinds of systems in our body. The most common that, you know, people are very worried about is pain. It can affect the joints in different ways. What is arthritis and what is arthralgia? Arthralgia is when the joints ache, but you don't see much swelling, you don't see much inflammation. And when it's arthritis, you see inflammation in the joints, you see a lot of swelling. And so there are like two different concepts that we deal with here. It can affect all joints, including hands and feet, smaller and larger joints. And when it's in some larger joints that are not very typically affected, we have to think about other disorders that might be related, such as a typical one is avascular necrosis that we see in lupus. We see it more frequently in lupus patients than general population for multiple reasons, but one of them might be steroid use, which Dr. Jolie is going to touch upon, and we're going to have a better understanding. So arthritis in lupus, it's different from arthritis in some other forms like rheumatoid arthritis. In rheumatoid arthritis, we see a lot more damage in the joints, we see a lot more deformities. In lupus, we don't see much changes in the radiographs, in the x-rays. We see that the deformities are reducible. We have a name for it, we call it Jacquot's arthropathy. And then when we try to correct the joints, they go into place. And the deformities in lupus, it's very rare to happen, but it's very common symptom, and a lot of people are worried about pain. And I'm going to go a little more in details about that. But again, I just wanted to emphasize that arthritis or inflammation in the joint, it's different from just joint pains. Lupus can also affect the lungs, the heart, and you know, when it affects the lungs, it can cause fluid around the lungs. It can cause inflammation of the outer layer of the lung, and it could be like uncomfortable, causing pain, to more life-threatening manifestations such as inflammation of the lung tissue itself, and sometimes even hemorrhage in the lung, which is kind of a life-threatening, and it's an emergency. It can cause also pneumothorax or pulmonary hypertension. You might have heard some of these terms. Pulmonary hypertension is a high pressure around the arteries, and you know, these are some of the most difficult manifestations of lupus we have to deal with. It can also cause cardiac complications. It can cause fluid around the heart, pericardial effusions. It can cause inflammation of the heart muscle itself. It can cause a higher risk of MI, and this is a very concerning topic because lupus predisposes people, even young people, to have a premature atherosclerosis or like coronary artery disease. And so we in lupus clinic screen people, we check the lipid profile to make sure we're on top of things, because we know that even young people with lupus can have a premature heart attack. It can affect the neurological system. It can cause complications, various complications, starting from headache to seizure to psychosis to stroke. And so we can all you know, need to pay attention to all these systems. Hematological, a lot of people with lupus have anemia, which could be different from other kinds of anemia. Could be hemolytic anemia, could be just anemia of chronic disease. It can lower the blood counts, the white blood cells, the thrombocytes. It can cause what we call antiphospholipid antibody syndrome, which is clotting, and that can cause many different complications as well. One of the most fearful complications of lupus is affecting the kidneys. It's called lupus nephritis when it affects the kidneys. Usually is diagnosed by biopsy because it's asymptomatic. And as doctors, when we see a lupus patient every 3 months, usually we check, among everything else, a urine analysis, because lupus could be quiet, but it could silently attack the kidneys. And we detect that in the urine analysis by detecting different things that shouldn't be in the urine, such as protein, for instance. It occurs mostly early in the course of the disease. And as I said, a biopsy is needed to stratify what type of lupus nephritis and how we can best treat it. Now let's move on to some more common features. How about fatigue? Fatigue, it's a very common symptom we hear about in the clinic, and at some degree we're all suffering from some degree of fatigue, but up to 80% of people with lupus experience fatigue, either chronically, throughout the whole time, or in periods. And fatigue may be the main symptoms and can be debilitating. And what contributes to fatigue? It could be the pain level, it could be medications, it could be disease activity, it could be poor physical and mental health, or it could be a combination of all this. It could be related to lupus or not. And more recently, there is a lot of growing evidence of lupus being, in two different types. Validating patient perspective of the disease, it's a very important thing. And we have something we call PRO, or patient-reported outcomes, that we commonly work with. When we try to capture a more comprehensive of the spectrum of the symptoms by getting the patient's perspective into that. And based on this, we kind of like try to stratify different types of lupus, because there is certain symptoms that are not measurable, such as fatigue, widespread pain, that might or might not be part of lupus. And the etiology is multifactorial. It could be non-immunological factors such as poor sleep or stress levels, and it's difficult to quantify, it's difficult to monitor, it's difficult to treat. And I mean, all these symptoms may not receive adequate attention by care teams. So that's why, developing these algorithms might help us as a clinician or the whole care team to care better about it. But how about fibromyalgia? Regardless of lupus, what is fibromyalgia? Fibromyalgia is a hyporeactive pain pathway. Researchers believe that fibromyalgia amplifies the painful sensation by affecting the way our brain and spinal cord processes painful or non-painful signals. It's very prevalent, and I tend to believe it's more prevalent in people that have one underlying autoimmune conditions or arthritic conditions. And so it's seen that people with lupus have probably a 20% higher chance of having fibromyalgia than someone without lupus. And the symptoms are intertwined with the lupus, are common features in both. So it's very hard sometimes to distinguish, do I have fibromyalgia or do I have lupus or do I have both, and which one is active at which time, so we can better address that. So there is a recent paper that was published, and they were trying to look at patient-reported outcomes, at the symptoms that the patient reported, and try to correlate that with the disease activity measures we do with a blood test and everything. And they found out that there is a type 1 when we see active lupus, but without fibromyalgia. There is a type 2 when the lupus is inactive. It doesn't show any lupus activity in the blood work. The lupus antibodies are quiet. Everything else is good. But there is this widespread pain, fatigue, which is predominant fibromyalgia. And there is a mixed also group when you see active lupus with fibromyalgia, and another group when we see minimal lupus, inactive and without fibromyalgia. So as you see from the breakdown, like lupus, it's it's more commonly you see lupus without fibromyalgia. So lupus itself, it's a very big concern. But in some cases, you see that lupus is inactive, and the main features are fibromyalgia related. That's about 8% of people with lupus in the clinic. Type 1 then, it's a classic inflammatory type of lupus with features including arthritis. Again, as I said, painful swollen joints, not just joint pain. Fluid around the lungs, around the heart, active rash, active lupus nephritis, or lupus affecting the kidneys. And this type of lupus responds very well to powerful immunosuppression therapies we have available. And this is measurable. We have different measuring tools. We have a tool called SLE, which is a questionnaire, like it includes all these different symptoms, and it includes the laboratory we use. And there is this also type 2, which encompasses mostly fatigue, impaired sleep, widespread pain, mood disorder, cognitive dysfunction, and there's other tools to measure this, and some of the best tools are patient-reported outcome. Implementing division of lupus in subtypes encourages, first of all, us doctors to address these important symptoms because they might be addressed differently. So this is a diagram that shows what is lupus and what is fibromyalgia. And you see in different dot colors, the fibromyalgia are just the blue dots, and you see is just sensitive to touch or widespread pain. You know, these are the most common features of fibromyalgia, like you're tender wherever you touch yourself, and there is some specific tender points that, you know, there is a map for that. But symptoms more common in lupus, you see they're marked with violet dots, and you see those are like way more measurable, like fever, skin rash, sensitivity to heart disease. And there is features that you can see in both, such as fatigue, brain fog, depression, headache. You know, it's very hard to sort out if the headache is related to active lupus or is something unrelated, or is something just fibromyalgia related. And how do you make that distinction is by measuring other lupus activity. And if the lupus is active and there is no other explanation for the headache, probably that's lupus related. But if the lupus otherwise is quiet, there is no features other than, you know, widespread pain or headache, probably that's more fibromyalgia related than lupus itself. And why is it important? Because type 2 lupus syndromes are addressed only in about 30%. We have a very short time to interact with the patient, and if we don't pay particular attention to all this, it's very hard to sort out all the symptoms in a best manner, and often perceived as lupus-related symptoms, but they may not be. And the treatment might be different, such as immunosuppression versus more comprehensive, like physical therapy, sleep, pain management discussion. Because if you give immunosuppression to someone that might not need it, you might cause more harm than good, and we don't want to do that. And that's why it's very important to kind of classify these two types of lupus, and so we can pay due attention to everything. So we treat the symptoms based on, you know, I mean, what is specific about it. So at this point, I'm going to take questions. And remember, rheumatologist is your best friend. So don't shy from asking questions, from being open with us. And we're open to discuss, you know, fibromyalgia, chronic pain, headache, everything that might or might not be lupus related. So I'm happy to take questions now. And thank you.
Great, thanks so much, Dr. Nika. That was really wonderful. I really like that you dove headfirst into the cutaneous lupus, because we do get questions about that, like, do they see a rheumatologist? Should they also have a dermatologist? Do the dermatologist and rheumatologist work together? Could you maybe talk a little bit about that process?
Yes. Us at Rush are very fortunate to have a great dermatology department. So we work hand in hand with a dermatologist. Sometimes lupus rash could be very easy to recognize, but sometimes, as I said, might be something else, and we might need their help, and especially might need a skin tissue biopsy to sort out if that's lupus related or might not be. And so, and besides treating the underlying condition, lupus, when it's active, we might need their help in picking the best topical agents or other modalities, such as steroid injections in the skin. So we work very, very closely with the dermatology. Usually when the skin rash is beyond like something simple we can treat or manage, we refer people to dermatology, mainly for diagnostic, but also for treating purposes.
Okay, and that includes even if they only have cutaneous, right? Or should they?
Yes.
Okay, so you see lupus patients with SLE as well as cutaneous.
I'm sorry, Mary, when it's cutaneous lupus and there is no systemic lupus, in that case, people might respond to topical agents, but they also may need immunosuppressive therapies. They may need systemic medications that we co-manage usually with dermatology, because we need to monitor the medications as well with frequent blood work or medication levels, compliance, and we need to make sure that you know, we're on board with that too.
Okay, great. Yeah, it's great when you guys work together. I know you work closely with nephrology as well, since so many lupus patients end up with
Absolutely. Yeah.
involvement.
So, yeah, we're also very fortunate at Rash. We have a great nephrology department. So,
Mhm.
once we start detecting some abnormalities in the urine analysis, such as protein in the urine, it shouldn't be there, or blood cells in the urine that shouldn't be there. At that point, we start thinking about referring patient to a nephrologist to determine if they need a kidney biopsy, at which point is best to get the biopsy, so we can stratify how much of the kidney is involved and what is the best treatment options for that case.
Yes. All right, we did get a question from Kristen. How do you diagnose fibromyalgia? What tests do you perform?
Okay, so fibromyalgia is a clinical diagnosis. First of all, is a diagnosis of exclusion. So when we see someone with fibromyalgia, as I said, they have fatigue, widespread pain, they might have headache, a brain fog, memory problems. We as doctors make sure we're not missing anything, such as inflammation. So we check the inflammation markers, autoimmune conditions, which could be in early stages. So we check an ANA, we check an anti-nuclear antibody to see if there is any potential for developing any autoimmune conditions. We might need to check the thyroid levels. We might need to check the vitamin D level. So there is different ways that we try to rule out other potential conditions. And once everything else turns out to be normal, there is no other explanation for feeling this way. And besides that, there is this tender points map. So there is certain tender points in our body that when we press upon, they're very sensitive, they're very painful. So it's a clinical diagnosis, and it's a diagnosis of exclusion. So yeah, that's how we approach fibromyalgia usually. And fibromyalgia could coexist with other conditions. We see it very commonly in rheumatology, coexist with a rheumatoid arthritis, with lupus. So by diagnosing someone with fibromyalgia, we're not ignoring the other diagnosis, but we try to approach both in different ways, so they have a better result.
Yeah, with lupus, since there is no one test, there are the test indicators, and it sounds like fibromyalgia is the same way. Is there a test for rheumatoid arthritis specifically?
Yes, absolutely. Yeah, there is a different, like a screening tool for autoimmune condition is ANA. There is also screening test for rheumatoid arthritis. One of them is called rheumatoid factor, and another one is anti-ACPA or CCP antibody. In majority of rheumatoid patients, those tests are positive, but there is also non-specific testing like high inflammation or radiographic changes that we can detect very early in the course of the disease, changes in the plain radiographs or ultrasound or MRI that show inflammation around the joint. So the combination of all this testing makes for the diagnosis of rheumatoid arthritis.
Okay. All right, we got another question from Andy, and I'll just read the whole thing. I felt that my rheumatologist kind of brushed off her SLE diagnosis, and from what you're saying, it should be taken more seriously, and there should be more going on than just Plaquenil. Do you want to talk about that? Because I know you can't comment on somebody's specific case because you don't have their medical history in front of you, but maybe the question could be a little bit broader, like what should somebody who's recently diagnosed with SLE, what are some of the tests that they should be expecting their doctor to run on them?
Okay.
Yeah, can you maybe explain a little bit?
Yeah. So again, as I said, lupus is a waxing and waning kind of condition. So it may be periods of exacerbation and it may be periods when it's very quiet. So once the diagnosis is established based on what we call the diagnosis criteria, but which also is an art depending on the physician, that making the diagnosis. So once you make the diagnosis of lupus based on blood tests, besides the ANA or the anti-nuclear antibody, we check the other specific antibodies, we check the blood counts and make sure there is no low blood cell counts. We check the urine analysis. We look for the symptoms specific like skin rash, alopecia, and all that. And so based on the degree of information we gather from the blood work, from the symptoms, and from observing or examining the patient, we determine if the lupus it's aggressive or very mild. If it's mild, the treatment also it's not very aggressive, because the treatment is tailored toward like the lupus severity. So you cannot use very powerful immunosuppressive medications to treat mild symptoms just because you're diagnosed with lupus. So Plaquenil might be sufficient at that time. And so that's why we monitor very frequently to make sure that we're on top of things and we detect things as they arise, so we can, kind of tailor the treatment. But yes, lupus can be very mild and it can coexist with a fibromyalgia. So the focus at that, and actually dividing the types of lupus into type 1 and type 2 is exactly what we're looking for, to be more specific about what we're treating at the moment. But, this is a progressive kind of work. So it's not, one size fits all.
Right. And I think that's because we do get that question a lot, like, how can I tell if my rheumatologist is treating my lupus effectively, and is this all that they can be doing? And it's difficult. We can't answer that question, right? Because we're not in a position to, and they would really have to see a new doctor in order to find that out. But there are some regular tests that need to get pulled, and there are some rules of thumb, and we can help with that. But it's really that's why it's so important to have a relationship with your doctor that you trust. It really is. It's important, especially when you have a chronic illness and you have to go to the doctor. Like, how often do you see your average patient? How many visits do they have a year?
So I was going to tell you, Mary, how we operate in the Rash Lupus Clinic, specifically for a condition like lupus, an autoimmune condition that could be potentially very aggressive. And it's very hard to predict from the beginning how aggressive it's going to be. So we see every lupus patient every 3 months, especially in early stages or when they're active. So every 3 months, we have a set of labs that tells us about lupus activity. That includes the double-stranded DNA that correlates with the lupus activity, complement levels, blood counts, urine analysis. There's other labs that we don't need to check this frequently, but based on the this set of labs, we can tell, and based on the symptoms and the physical exam every 3 months, we can tell where the lupus activity stands at that time, and so we can approach that appropriately. Sometimes I tell my patients for conditions such as lupus, which are very, very, aggressive, it could be, or difficult to deal with. Sometimes it might help to get a second opinion if you're not comfortable with a doctor. And honestly, I tell that to my patients all the time, because we can do so much and we're always trying to do our best. But if you hear that from a different angle, from a different perspective, it might help as well. And so that's why we do these community events. And because probably, we can all share something that might sound familiar or might not, so it can help us in making decisions about our care.
Absolutely, because I think the stress of being diagnosed with a chronic illness can be really upsetting. And with lupus, there isn't one test you can do. So what we always suggest is, for a second opinion, we ask them to see a specialist, somebody who specializes in lupus. And if they are looking for a new rheumatologist, we always suggest they contact the rheumatologist and ask, how many lupus patients does this doctor see? Does this doctor do lupus research? Something to kind of gauge their experience, because again, the labs are indicators, but since you see lupus patients and the lupus clinic is for lupus patients, so you see lupus patients all the time, you're probably more familiar with
what to look for and
what is lupus, right? Because it is, an imitator. So it was a really good question, and thank you for answering that. Here's a question from LaShawn. In what situation do muscle involvement occur with lupus, myositis versus lactic acid buildup? Any relationship or considerations?
Okay, so myositis is also could be a symptom of lupus. And myositis is inflammation of the muscle. So it could be a different autoimmune conditions. It could be just polymyositis or dermatomyositis, or it could be lupus related. So when we suspect inflammation of the muscles, as far as the clinical symptoms, you see weakness in the muscles besides pain, you see weakness. Then you check the muscle enzymes and you check LDH and you check other specific testing that are directed towards like trying to detect what's going on with the muscle. And if you see that, there is inflammation in the muscles shown in the blood work with high inflammation titers, high CK levels, high LDH, then you might need to proceed with some more specific testing like a muscle biopsy. You know, myositis could coexist with lupus, could be an overlap, could be part of lupus, but if there is inflammation in the muscle or myositis, then you have to be more specific about targeting, first of all, diagnosing and targeting that.
Okay, great. Another question, and we get this one a lot, and I know you went through this, but can you explain a high ANA? And is there a way to get it a better zone for the ANA?
A better zone?
Yeah, I'm assuming they mean, is there a way, like with high cholesterol, is there a way to monitor, like to adjust your
Yes. So as I said, ANA is a screening tool for lupus, but by no means it means that someone with a positive ANA has lupus. And us in rheumatology see a great deal of new consults with just a positive ANA. And ANA can be detected in very low titers in a high percentage of population. As I said, in low titers 1 to 40, you can see it in up to 30% of general population. As the titer goes high, it raises the concern about developing some autoimmune conditions. So if you happen to have a positive ANA, the way we approach that, we look at other like symptoms, other blood tests, and to determine based on how high the titer is, if there is a need for frequent follow-up. And so if there is no other symptoms, there is no other markers in the blood work that raise a suspicion for an autoimmune condition, you just observe that over time. And so you might want to repeat the ANA at a certain interval depending on how high the titer is. And sometimes you see that that starts to progress. In that case, you'd be more alert and more concerned about progression into an autoimmune condition. But if the ANA titers remain stable over time, there is no other signs and symptoms, there is no other blood work abnormalities, an ANA itself might not be of concern. And as I said, you can see a positive ANA like post-viral infection or in people with other autoimmune conditions such as autoimmune thyroiditis or inflammation of the thyroid gland.
Okay. All right, great. Here's a question from Anita. It's being recommended that I try leflunomide. Is that how you say it? As there is medicine for me between Plaquenil and methotrexate. I can no longer take Plaquenil because due to macular degeneration. Can you tell a little bit about that, about the medication?
Okay.
Okay.
So based on this little scenario, I think that the most prevalent symptom of this person with lupus is joint pain or arthralgia, because leflunomide is something we use to treat arthritis. We use that in rheumatoid arthritis, and we use that in lupus patients with arthritis. So it works very well specifically for arthritis. It might work well in some other, there is studies that show that leflunomide is good for kidney disease as well. So it's an anti-inflammatory or disease-modifying agent used more commonly for arthritis. And if Plaquenil, which is the first go-to drug for lupus, and I like some phrase by Michelle Petrie, which is an expert, worldwide expert on lupus. She says that Plaquenil should be in the water of people with lupus. So it's so important in all levels that Plaquenil has shown to be beneficial. But if someone is intolerant to Plaquenil or has developed macular degeneration, then we have to move on to other, a little more aggressive drugs, and leflunomide could be one of them.
Okay. All right, great. We have a really interesting question about CNS lupus, and it was, I'll just read the question. Developed while being, it's from Miranda. Developed while being off Benlysta 6 months due to hospitalization and COVID vaccine, developed CNS lupus, neuropsychological eval revealed, cognitive function, slow processing, verbal memory, and term memory. Now that I am back on medication, my mood disorder stopped. Will the cognitive symptoms go away as well?
So I tend to believe that if neuropsychiatric lupus happened due to active disease, by attacking the underlying disease, lupus in this case, you hope that by trying to calm down the inflammation, at some point the cognitive deficiency that developed with that might get better if it was related to, active disease. That might take time, but with use of proper immunosuppressive medications and, trying to put the disease at a lower active state, the cognitive dysfunction might return as well.
Okay, great. So that's good news. Here's a question back to ANA. I should have asked it a minute ago, and you may have answered it, but Mari asked, what is the normal range for ANA?
It depends. There is a new set of criteria for lupus that just came out in 2019, and the entry criteria, that is 1 to 80. So now everything lower than 1 to 80 shouldn't be considered positive. It used to be 1 to 40 before, now it's 1 to 80. So if you have an ANA 1 to 40 or even 1 to 80, that's considered a low titer. You may or may not call it positive, but 1 to 80 is the cutoff right now.
Okay, and then another question from Mari, how often should your rheumatologist check your ANA?
So there is no clear answers to that. You might not need to check ANA again if you have enough information. If the ANA is just a positive ANA and there is nothing else, but you want to make sure you're not missing something, depending on the titer, you may decide to check it again in 6 months or a year, or depending on what new symptoms start surfacing. But if you have an established diagnosis of lupus or some other autoimmune conditions, because ANA also can be seen in other autoimmune conditions, like people can have rheumatoid arthritis and have a positive ANA, or thyroid disease and have a positive ANA, or scleroderma and have a positive ANA. So if they have an established diagnosis, you don't need to check the ANA any longer. But if they don't have an established diagnosis and it's just a positive ANA and there is nothing else, depending on the symptoms, you decide how frequently to check that for progression.
So it's not really the kind of thing that you're going to take regularly, like you keep an eye on the kidneys, right? You take blood tests.
There is a different type of ANA, double-stranded DNA, that correlates with the lupus activity that we check in the clinic every 3 months.
Okay, so that's the Smith DNA, you said?
Double-stranded DNA.
Double-stranded DNA, pardon me. Okay, great. All right, so here's another question from Andrea. Is tendinitis in multiple parts of the body in addition to joint pain indicative of lupus?
Tendinitis is not a very common symptom in lupus. So it may happen, but it's not very common. So it could be just because lupus can coexist with anything else. So I tell my patients, having lupus doesn't exclude someone from having common like tendinopathies, like inflammation of the tendons. So it depends on how active the lupus is, where is the tendinitis, but also could be unrelated as well.
Okay. And then we got a comment. Somebody was just thankful, and the individual sounds like she's relatively new to the lupus community. And it is frustrating for people with lupus, especially when they're new, because there's so much information they have to learn. Is there anything that you tell your patients early on in the process that can kind of help them acclimate to this new world that they face?
We try to share as much information as we can. We use a lot of resources, Lupus Society of Illinois, all the support groups, everything, we have available. We try to see them more frequently in the beginning. We tell them that, having lupus doesn't mean the end of the world. It may or may not be aggressive, and we're here trying to stay ahead of the game and trying to detect aggressive features as early as possible so we can intervene. But just diagnosing lupus is like diagnosing any other conditions. I tell my patients it's just like getting diagnosed with diabetes, for instance, or high blood pressure. You might be having a very mild disease that can get controlled with one medication, or you might, start developing more aggressive features and you might become very resistant to treatment. That's something not to fear from the beginning, because like anything in life, can happen, but just staying compliant with medications, staying compliant with your doctor's appointments, and being confident that, you can succeed in fighting lupus. It's very important.
Yes. And, you know, you bring up a great point that the LSI, we can help fill those gaps. Like we provide educational events like this. This will be recorded and we'll refer to it when people call in and ask a question. We can direct them here. The support groups, and LaShawn spoke a little bit about that earlier. I think she may say a little bit more before the panel discussion. She's an amazing support group leader, and she has 2 groups. We have another support group leader I know on the call or on the video, Mari, who has also 2 groups, one of them virtual exclusively. So that you can't underestimate or overstate how important it is to talk to other people with lupus, right? Because even though it is so unique and no 2 people have the same disease, a lot of people have similar experiences, you know. So
we're very fortunate in Chicago. We have a large lupus community. We have you guys. We have a lot of lupus support groups. So there is a lot of resources.
There are, yeah, and I've actually, yeah, Chicago does have excellent resources. All right, it looks like that's all of the questions that we have. We're a little bit ahead of schedule, which I don't know about you, but I'm fine with. We'll have more questions for you, I'm sure, during the panel discussion. But right now, I think we're just going to take a break. Yeah, we're just 3 minutes early. So we'll be back at 11:50 with the 3rd presentation. And thank you so much, Dr. Nika, for the—
Thank you, and happy holidays to everyone. Thank you.
Yes. All right. Thanks, everybody.